Like I said earlier, it's been an incredible privilege to be in New Zealand for the last 2 weeks. And I want to thank the Health Quality and Safety Commission and Ian and everybody else for inviting me and for welcoming me to be part of your community, at least for a little bit. In the spirit of reflecting backwards, I think I've been working with the commission and with Ian in particular back to the beginning of this, probably to 2011. So we knew each other on Skype way before we ever knew each other in person. And this is probably a great way to wrap up my trip so far, and that's to talk about what next. And the first time I knew I was going to talk about what next, it was to see the title in the program, but I had no idea what that meant. And so I sent an email to Ian, and I asked him, and I think basically I got permission to be a little bit of a muse and maybe walk all over the place some. So there's a theme here, which I think you'll pick up on relatively rapidly. I am not an oracle, even though I may be an icon. So we'll see. There you go. So when I was getting ready with that challenge to talk about what's next, I started to go through all of the work that I've done since I left practice in 2001. And this was my conclusion. The best way of looking forward, for me anyway, was actually to look in the rearview mirror at how far we actually have come in the last decade plus. So I went back and I found a presentation that I actually gave in 2004. So this is 14 years ago. And this was its title, Crew Resources Management or Crisis Resource Management in the Operating Room. And I gave it as part of this thing they used to call a breakthrough series with the Institute for Healthcare Improvement. And the Institute for Healthcare Improvement in the United States, at least, and I think pretty much internationally, is recognized as one of the organizations that's really pushed this idea of safety and safety culture and the importance of leadership. And it was really the first one back, in the early 2000s to take up this mantle of we can be safer in the operating room. And I actually, at the time in the US, was one of just a handful of surgeons who were really, really interested in this. And I want to show you some slides that actually came from this talk. This is 2004 now. All right, this was my kickoff slide. I think it's wrong that we walk into operating rooms every day and not everybody even knows everybody. Now, I'm sure there are large hospitals represented amongst you and very small ones, and probably in the smaller ones, it's less of a challenge to know who's standing in the operating room with you. But if you're in a facility where, traveling nurses or locums are coming and going, actually maybe this isn't a non-issue. But back in 2004, I actually had some rather embarrassing moments in my own operating rooms where I forgot the name of the nurse next to me who I'd worked with for 5 years once, and then ended up the entire operation just trying to avoid saying her name, which was uncomfortable and really bad and wouldn't have happened if we just had a short period to go around the room. My other cure for that, though, was to use a whiteboard to put people's names on. All right. Everybody in an operating room ought to know everybody else's job and understand that everyone's efforts are needed to get the job done. So we saw the tribes. One of the things we don't do very well in healthcare in general is actually spend some time working in another tribe for a little while to see, even for a few hours, what their job is actually like. I don't know of a surgeon, at least, who ever scrubbed, even for a small case, and was a scrub nurse. I know very few surgeons who've gone around and stood with the anesthesiologist while they're administering anesthesia. And we just don't do that. And I think this idea of kind of walk a mile in my shoes is incredibly powerful in terms of us really understanding what somebody else's job is and appreciating even more how important their contribution is to the function of an operating room team for the patient. So in this talk, I defined what is a briefing. And we've talked all about briefings here, but basically it's a discussion trading information back and forth. But back then, that was like a foreign language. People didn't use that word anywhere near operating rooms. I suggested to the people who were listening to me that day that actually we might want to use a checklist in our briefing. And remember now, this is 5 years before the WHO Surgical Safety Checklist was actually launched, and you can see many of the same elements that we currently actually put into timeouts I suggested in a slide a long time ago. Now, it's not to take credit for any of these ideas. These ideas were actually borrowed from other people, but I think for me, when I went back and I saw this presentation, this stuff's been kicking around for a while. It's 14 years later. And if I were to look 20 years into the future, a big hunk of what I hope we do is actually to finish this trip, to make briefings really real, to get the best out of the checklist, and to really work on making operating room teams as functional as they possibly can be. I suggested, because of my own weakness actually, that people think about putting whiteboards in their operating rooms. I don't know how many of you have that, whether that's standard practice here, but it became standard practice in any operating room where I was given the privilege of operating on patients' hearts, I can tell you that for sure. And we put all kinds of information up there, including everybody's name and role. And when you came and left from the operating room, you erased your name and the new person replaced their names, so we always knew if the anesthetist was going to switch out in the middle and the case was too involved that they couldn't tap the surgeon on the shoulder and say, I need to take a break, that at least you could look at the board and tell who was on the other side of the ether screen. And again, this thing with names, I have a weakness for names. I'm really not very good with names. I forget people who I've known forever, and this really helped me. It absolutely did. I talked to them about what a debriefing was, and we've heard today a lot about how we struggle with both the sign out and with the debriefing. And I can let you know that, honestly, that's a universal struggle. Hospitals across my own country struggle with doing a good sign out. And I was talking about this just a couple days ago in Wellington about how important the sign out is for our patients, right? One of the most important elements, if you're in a place that takes specimen, is actually making sure that the specimen is labeled right and that the name of the patient's on it and that the specimen is going to be handled the way that it's supposed to. And the nurse who was sitting next to me on the little panel, she said, yeah, we did a case not too long ago where the specimen just disappeared when we were done, and it was the only reason why the patient had had a surgical procedure. In my own career, I've seen several patients, including a young woman with breast cancer, where the specimen was actually lost, and it was the entire thing, and it was just gone. And so now what do? You took it out because you thought it was cancer, and you don't even know. But this piece too, I think I want to talk to you for just a minute about debriefing, because the opportunity here is to catch the problem and fix it. And Ian referred to it earlier, but I think that in order for debriefing to work, you have to have the elements that he talked about. Capture the information, then make sure it goes to somebody who can fix it, and then give the information that it was fixed or it couldn't be fixed back to the person who actually raised the issue in the first place. And why is that so important? Well, I can tell you from a surgeon's standpoint anyway, you're only going to complain so many times to have the complaint not dealt with before the day will come when your light will go amber and then red. And that happened to me. I was relating it the other day. In the operating room, I used to do heart surgery, so we did a lot of median sternotomies and used wire because it was cheap and it worked to put the sternum back together again. And that's great, and it's really easy to do technically, but at the end, you have to have something to cut the wires. And I kept getting wire cutters passed up to me that would do a great job at nibbling on the wires, but didn't do such a good job of actually chopping it up. Well, I complained, and then the next case I complained, and the next one I complained, and clearly no one was listening to my complaint until me, who's actually a pretty gentle, affable soul, loses it over a pair of stupid wire cutters. Well, I will say one thing. It was effective because it was followed within hours with a system of how to make sure the wire cutters were actually sharp. But that's the magic of this. This works if you build a system to support it and then show people that it actually works, right? We caught this. There is a hospital in South Carolina in a little town called Florence that now has computerized records of 130,000 debriefings. Not only have they captured all the information, they have organized it into clusters. They have cut operating room time by 20% because of catching all these problems all over their operating rooms and then fixing the problem. So this can matter. It really can. Why teamwork matters. We've been talking about that basically all afternoon, but this is what I said to people back 14 years ago. Most endeavors in medicine require groups to work together. That's like a big duh. Professional training, though, focuses on technical and not interpersonal skills, right? I mean, we saw up there that now the college offers some surgical education training for people who spend probably 30% of their time doing training, right? And now there's a day where you learn how to be a trainer, which is a step in the right direction. But this is the same thing. We actually spend most of our time using our non-technical skills, not our technical ones, and yet we spend zero time actually training them until there's things like MORSIM out there. The overwhelming majority of accidents in medicine involve fundamental communication failures. Now, I believe this deeply because by the time I talked about this, I had worked for our version of the ACC for 3 years. I had probably already seen more than 100 malpractice cases involving surgery coming from Harvard University associated hospitals that are supposedly perfect. Well, I can tell you they are not. And that 70% of the time, it was a communication failure that sat at the heart of one of these things that went wrong. Now, half of the time in the operating room, the problems are technical. They absolutely are. And patients will sue for technical problems. But you know what? Those half the times where there's a technical problem, there's 2 ways they can be resolved. One is to be resolved well, and the other one is poorly. And the poorly comes because of bad communication. So we have a chance to rescue. We cut the wrong thing. We can rescue, put it back together. Instead, communication breakdowns, the problem doesn't get fixed, and pops up for the patient 5 days later, and then a lawsuit in the end results in the United States. So this kind of stuff we need to work on, and that's what I said 14 years ago. And then finally, this idea of setting the tone. I've been singing this song for a long time, and I had a chance to sing it to you today, and I think I have Ian as a convert because he's, I think a long time ago, adopted it into his own practice. But this cool little sentence, I don't have pride invested here. I'm gonna do something that's like really dangerous. I just want to see this get done right. So if you think of anything helpful or see me doing anything wrong, please let me know. The message that a surgeon sends to the people around them with that kind of a statement is so powerful about how they actually recognize publicly that they need the help of others, and they not only do they want you to speak up, but they expect you to speak up, right? I used to see that in heart surgery all the time. I would be paying so much attention to what was going on in the operative field. I wouldn't have known if there was an earthquake in the hospital. And oh, by the way, twice I was standing in operating rooms in San Francisco when the wall shook. And I actually have a tile that fell on me that I've kept in my collection since 1987 from the last big earthquake in San Francisco. So, what was I advocating for in 2004? Briefings, debriefings, checklists, and teamwork. And what have we heard about all afternoon? Briefings, debriefings, checklists, and teamwork. And what does that say to me 14 years out of the gate? We're not done. And it's a long path. And we need to keep working. And we need to not get frustrated. Because persistence will win. The culture is changing, but we're not there yet. So, my conclusion, we're not finished. And I think we've heard it over and over again here. But it's a hill worth climbing. the OR theater that we're all trying to make, we may end up in someday, but not on the giving end. It could possibly be on the receiving end, and we want everybody to get the best care in that place, and we're not all the way there yet. And we heard some of those stories just in the last few hours. So, just in the last little bit then, I'm going to muse past that past message, because I think every single one of these things needs more work. So what's ahead? Well, I saw this slide probably 6-7 years ago, and it actually was put together by a pharmacist who was trying to figure out how to move the safety of giving medicines, really high-risk stuff like chemotherapeutic agents and that kind of thing, safely in hospitals. And this was the ladder that he put together of how we try and prevent problems in medicine. And I think this will probably resonate with everybody here who's worked in a hospital or in a clinic or wherever. The first thing we do when we're trying to prevent something is just to teach people. Don't do that, don't do that. Pay more attention, right? Then the next level is, well, we need a class. We're going to send you to a class or a webinar or something like that. And then we kick it up, and we really want to be hard now. We start making it into rules and policies. Now, the problem with rules and policies is, actually, unlike the class that they make you go to, no one has to follow the rules and policies unless somebody enforces them. And a lot of times, honestly, they don't get enforced or followed. The next thing is the thing that we've been talking about today, which is checklists and systems to double check, then standardization and protocols, automation and computerization, and finally forcing functions and constraints. And if you look at a companion part of the world that's taken this pyramid on, it's in the cockpit, where we've done a lot of this kind of thinking. But planes still have pilots, right? I think it's going to be a long time before we see commercial aircraft without pilots in them. Could it happen? Yeah. Could planes be flown today without pilots? There are plenty of drones out there that aren't falling out of the sky all the time, although some of them do fall out of the sky. But moving up this ladder is something that's been done there. And my point to you is not that we need to get rid of people in healthcare. That's impossible, because the patients we take care of are too variable and too unpredictable. But what we can do better is to march up this ladder as far as is appropriate for whatever it is that we're trying to fix. So let me tell you a quick little story out of an intensive care unit back in Boston, where I live. It's at the Beth Israel Hospital, and they were doing open heart surgery. Been doing it for a long time. They had 6 surgeons there, and they were actually trying to be up to date. And I don't know how many of you know, but there's been a tremendous emphasis in heart surgery for control of blood sugar in both diabetics and normal patients, because it makes a difference in both, around the time of cardiac surgical procedures. You can almost eliminate the risk of a severe infection in the middle of the chest by appropriately keeping the blood sugar under 200. That takes some kind of an order set to guide the nursing staff in the intensive care unit to do it. There were 6 surgeons. Guess how many order sets there were? There were 6, right? And what kept happening? When they did audits of how well blood sugars were being controlled, the control was terrible, and there was low blood sugar flying all over the place. And so they talked to the nurses, and they're like, well, we get there, but we can't remember whose order set, and then we have to go to the chart, and by then we've lost our place, and we come back and we can't. And it's really a problem. So the chief took the 6 surgeons, put them in a room, and said, don't come out until there's 1. And they emerged with 1. They wrote a paper about it, but the 1 took the best of the 6, and now the nurses only had 1 to follow. The surgeons at the end of the day, there actually was no real good reason except they wanted it that way for why there were ever 6. The time blood sugar was controlled went almost up to perfect, and the number of low blood sugar events went almost to 0. That's not the only thing like that in healthcare. We can actually do better at working on that kind of stuff together to get rid of the variability that we don't need, so we can keep the ability to customize for all of us, because we're all individuals and different, when we do need it. We've got a lot of work to do. I'm going to guess that same thing is present in all of your operating rooms and all of your hospitals. Why does Dr. X give antibiotics and Dr. Y doesn't give antibiotics, but they look like exactly the same patient? And we don't talk about it and we don't fix the problem. At our children's hospital in Boston, we actually looked at what was the predictor of whether or not a surgeon would give a child an antibiotic when they came in with acute appendicitis, which they were going to take the appendix out. The only predictor of that behavior was where the surgeon had trained. That was it. So whoever taught them, they were teaching them something that was going to stick for life. But it had nothing to do with how the patient looked, whether they were sick or not. It had nothing to do with anything except what a mentor had planted in their brain earlier in their careers. And we need to fix that kind of stuff. All right. We can also learn from others. And to me, this is this really cool little triangle that shows the relationship between leadership, which we've already heard here, is really, really important in our hospitals. To stand behind the safety culture that we want to push. Making a safety culture at another point, and then being devoted ourselves to constantly making things better. Not becoming complacent. Not being satisfied that the way that we do it now is the best way that it could ever be done. Which means we have to keep asking ourselves that same question, could we have done better? Now, a lot of the learning, honestly, has come from when things go wrong. And to a point, that's okay. But we also need to start thinking about getting ahead of that a little bit to keep things from going wrong. But this combination, strong leaders, working on culture, and then building in ways of making things better by capturing near misses and acting on them, this to me is the magic for how we make ourselves as good as we can possibly be in healthcare. Now, this is just to show you what's been done in aviation since way back there in 1960. Back in the 1950s, I don't know what it was like here, but when planes would fly up and down the eastern seaboard, the radios actually wouldn't work well enough to allow for communication at any level except straight down. So the airlines actually would put people on radios scattered about every 20 miles on a telephone, and they would communicate. So you can imagine, we've come a long way, and you can see it here in the safety numbers. But the interesting piece to me is they aren't done. They are still working. Not now to eliminate accidents, which has been done pretty much. I mean, it sounded like there were problems getting out of Nelson. Part of the problem was they were probably trying to be safe because the weather was saying don't fly, or maybe their alarm went off in a plane and said don't take off. Whatever, they worked on it and they keep working on it. And to me, that's the message from this slide. Even when we think we're done, we're not. All right, so 4 places that I think we can think about: standardization of things, teamwork and communication, which we've talked about all afternoon, culture, and then finally this idea of technology that supports us in our work, not that gets in our way in our work. We have a huge problem in my country right now with the electronic health record. It is an abject disaster. It's great at creating bills to send insurance companies and terrible at collecting information to help patients. But there is technology that can help us more than it helps us now. And that's going to be a place, I think, where there's tremendous opportunity for us to improve things for our patients and for ourselves. So I plead with you to keep working on your briefings. It sounds like when you can get them going, that even everybody on the operating room team comes to see the value in having a briefing at the beginning of the list. All right. More and better debriefings. And here, I would absolutely encourage you to think about ways of capturing information out of your theaters that can be fed back in to make them safer and more efficient and less frustrating for everybody who works in those environments. You cannot just go through the motions of a debriefing if you're not going to use the information. Don't do it. Don't even bother. But if you're going to invest and do it, capture it, and then do something with it to make the system better. And then people will do it more. Just like people can get the instant gratification from a well-done briefing and having the equipment they need in the operating room, the same thing can be true with problems you identify if you go and have a system to catch and collect and then correct. All right, we talked about more sim. I think programs like that, just like Ian said earlier, that needs to be business as usual in healthcare. If you compare us to many, many, many other industries in the real world, we don't spend a lot of time training as teams. We really don't, and we can do a better job of it, and we need to, particularly in operating theaters. And then an idea that we've been using a lot, we used it in South Carolina, is this idea of creating auditors who can educate and coach, right? So the purpose of an audit might be to gather information, to take back and see where the world is. But what a lost opportunity that a report doesn't get created that's given back in a positive way to say, we were there, we saw what you're doing, have you thought about this? And a lot of times we don't. We'll pay for auditing, but we won't put that little extra bit on there and use people actually as coaches. This is the reality of our world, okay? I can't, like I said, I'm not a soothsayer, I'm not the Oracle of Delphi, I don't have a crystal ball like Merlin, I can't do any of those things. But I can tell you this, because I've watched it every single year, both that I did surgery and since I left the active practice of surgery. And that is, that place is getting more and more and more complicated. More grafts, more prostheses, more screws, more widgets, more monitors, more, you say it, and we're getting more and more technologic, but we're not accommodating with all the stuff that it takes to make those things work. And the biggest one to me is to have teams in the operating room that work well together as teams. I think all the stuff I showed you from South Carolina says people actually like that. They feel better in those environments and they provide better care, reflected in the outcomes that they achieve for their patients. So we need to work on communication and respect and coordinating with each other, having people speak up. And I told this little story yesterday, and I want to tell it to you again today, because what happened to me in a lot of ways changed my life, and it committed me personally to this idea of helping people speak up. So I didn't show you a slide from 2004 that specifically said, help people speak up. But it's something that I've actually believed for a long, long time. And then I learned literally the lesson of my life almost 10 years ago. Actually, it was 9 years ago at the end of the upcoming April. When I went into work, and fortunately for me, at the time I was working right across the street from one of the best hospitals in Boston called the Brigham and Women's Hospital. And I went into work and I hadn't been feeling really great. And I'd gone to my primary care physician and asked him for a treadmill, and I actually had a treadmill test and supposedly it was negative. But that day I went into work and I sat down at my office and spoke with a medical student. And then the medical student left and my assistant came around the corner and tried to talk to me. And I was unresponsive and blue, sitting in my office chair. So she screamed, which was like calling 911 inside of a medical building. And who descends but a bazillion doctors, right? So there's like doctors at every turn, registrar equivalents, and I'll never forget this great big 6'6" tall, 71-year-old retired transplant surgeon. And they descend on me and they start resuscitating me in my chair. Well, fortunately for me, and the only reason why I got to visit you and stand in front of you right now, I was on the same floor at the Brigham and Women's Hospital where they train nurses to do CPR. So I've got these two dumb doctors trying to save my life, doing CPR in a chair, and over comes the boss. So you can only imagine, she was, I don't know, she was in her 50s, and she'd taught CPR since forever, probably before it was invented. And she comes over there and unloads on these two, right? Talk about speaking up. Well, she spoke up to the two doctors, said, put him on the floor. And oh, by the way, that's not how you do chest compressions. And basically, she started to run the resuscitation there. I ended up being taken from there across the street to the catheterization laboratory. A balloon went up and a stent went in, and they saved my life. And it's why I'm here right now. But if she hadn't spoken up, I couldn't have made the trip to New Zealand. I couldn't have talked to any of you. I couldn't have done any of this. And it makes a difference. And that's what I'm telling you, okay? I'm one survivor because somebody spoke up. And there'll be others, and it's one of the reasons why it's so important that we keep working on this. It really is. Until everybody feels like they have a voice if it has something to do with the safety or care of our patients. So we need more support for our surgical teams. Technology, I think, is going to be a big piece of it, but all this other stuff is so important. Now, I want to give you a little example of the kind of technology that they use up in the cockpit that could be helpful to us, at least the thinking that goes behind it, and that's this thing. There's radar now in these airplanes that actually can see inside of storms. It used to be a huge weakness. They could only see to the edge of the cloud, but now they can actually see moving things inside of the cloud and can go around thunderstorms instead of, like they did in the old days, actually going through it and sometimes crashing, right? So to me, this translates into one of the last things I want to talk to you about, which is this idea of making things we cannot see seeable, and that we need to work harder on that. One of the things that we can't see a lot of times is threats to the safety of our patients. And I think a lot of the things, again, that we've talked about this afternoon, we have talked about that. We actually, in a way, are already each other's Doppler radar in the operating room. But we have to become good at making things that may not be seen by others actually visible, right? So making invisible things visible, because you can't deal with the invisible. All right, I talked about a little bit earlier about learning from debriefs. This is an extension of it. These are some things that are kicking around out there right now. I'm involved in a little project with another hospital across town that's actually an OR black box. The same gizmo that they put in airplanes, a different version of it is being put into ORs on a test basis, so that when stuff goes right and goes wrong, people can actually go back and deconstruct events. And then there's this other thing that I think we as a system can do better, and that is creating ways of collecting events with an eye toward doing something with the information. This again is a huge problem. It works in aviation because they do something with the information. They communicate problems and they focus fixes on fixing problems that are identified. We are pretty good at collecting stuff, not so good all the time at dealing with all the information that we actually collect. And as we heard earlier, for a lot of these systems in healthcare anyway, the threshold for putting something in the system is actually all over the place. Sometimes it takes a whole lot to get somebody to trigger it, and other times it takes hardly anything, which really makes it difficult to deal with. We have a big hole, I think. We talked a little bit about this, and I was interested in your metric of days alive. Is that it? Yeah, days alive. It's getting to this, I think. It's something we don't do very well in our healthcare system, and what we really ought to be caring about is what happens to our patients over time. Not just what happens to them when they're in our direct care, like a hospital, but what happens after they go home. You know, we do a bypass operation, and we'll suppose that a year, nobody's better, really, but we don't even ask. So I think we need to do more of that. And one of the things that we're working on back in Boston actually is taking smartphones and being able to do all the things that they're capable of, counting steps, but then some really other interesting stuff, measuring social activity. It's just starting in the US, but I can give a patient an app now that will count the number of emails they're sending, count the number of phone calls they make, count the number of messages or texts that they send, and it creates some very interesting data patterns. But you can imagine if you do a really major surgery on somebody and you watch their activity, when they get operated on, everything goes down, and then it takes weeks, actually, for all those things to normalize back up. And we've never used information like that. And why bother? Well, my guess, our hypothesis, is that people's resumption of those activities actually could be a pretty sensitive way of knowing whether they're getting better or not, or whether we should call them back in. They're scheduled for their 30-day follow-up, but boy, you're not making any phone calls and you're not making any texts, and I'm a little worried about you. Can we get you back in? So just an idea that's out there, but I think a fascinating one. All right. This is the reality of where you guys work. I have marveled at it since the very first time I ever worked into an operating room. It is this incredible place where everybody wears a mask. Well, in my country, everybody wears a mask. In yours, it's a little bit more variable, but probably the masked banditos are the ones with the most power anyway. It can be very hard to hear. It is complex and often chaotic, and finally it's filled with human beings. And none of this stuff is going to change, I don't think. I really don't, until one of us can be replaced by a robot or something, which I also don't see happening anytime soon. So let me close with my final hope for all of us in doing this kind of work. My hope is that the changes that have begun will continue. All the good things that you were talking about, that we continue that, and that the theater will continue the march towards the very best care for every patient, every time, everywhere. When we started with the WHO Surgical Safety Checklist, that was the goal of the group of people who got together. It was designed for every patient to be used every time, to be used everywhere that surgery was done. We're marching, but we're not there. We still have work to do. We can make the theaters a better place. I know we can, and it's people like you that are going to do it. So thank you very much.